Let's explore high-yield key points on heart failure, focusing on its clinical manifestations and diagnostic criteria. 68-year-old male with history of hypertension and type 2 diabetes mellitus presents to the ER with progressive shortness of breath over the past 2 weeks. He reports a productive cough with frothy, pink-tinged sputum. He also notes worsening bilateral lower extremity swelling and has been sleeping on 3 pillows at night to breathe more comfortably. On examination, blood pressure 160/90, heart rate 102, respiratory rate 22. Physical examination reveals JVD, bilateral rails, and +2 pitting edema in both legs. The chest x-ray shows cardiomegaly and bilateral pleural effusions. Which of the following is the most likely diagnosis? COPD, acute bronchitis, PE, heart failure, or pneumonia? The correct answer is heart failure. The patient presents with classic symptoms and signs of heart failure. This includes progressive shortness of breath, orthopnea, paroxysmal nocturnal dyspnea, bilateral lower extremity edema, and cough. The presence of jugular venous distension, rales at the lung bases, and cardiomegaly on chest x-ray further supports the diagnosis of heart failure. COPD is less likely since the patient's primary complaint and symptoms are related to fluid overload, rather than chronic obstructive symptoms of progressive shortness of breath, chronic cough, and sputum production. PE usually presents with acute shortness of breath, not progressive shortness of breath, with chest pain and tachypnea. Pneumonia typically presents with shortness of breath, with fever, cough, or chest pain, with radiographic findings related to pneumonia that is not related to fluid overload. Heart failure is a chronic medical condition characterized by the heart's inability to pump sufficient blood to fulfill the body's requirements. This can happen in two ways. Either the heart's ventricles can pump blood hard enough during systole, called systolic heart failure, or not enough blood fills into the ventricles during diastole, called diastolic heart failure. What are the classic signs and symptoms of heart failure? These include peripheral edema, dyspnea, orthopnea, paroxysmal nocturnal dyspnea, crackles, elevated central venous pressure, and S3 heart sound. Heart failure caused by left ventricular dysfunction is categorized according to left ventricular ejection fraction. A 63-year-old male patient presents to his primary care physician with complaints of increasing shortness of breath, fatigue, and decreased exercise tolerance over the last few months. He has history of hypertension and hyperlipidemia. On physical examination, his blood pressure is 150/90, heart rate 88, respiratory rate 20. He has an S3 heart sound and there is +2 pitting edema in his ankles. An echocardiogram reveals left ventricular dilatation with ejection fraction of 35%. Which of the following is the most likely underlying cause of his heart failure with reduced ejection fraction? Myocarditis, valvular heart disease, CAD, or hypertension? The correct answer is CAD. This patient is presenting with signs and symptoms of chronic heart failure with reduced ejection fraction. The combination of shortness of breath, chest pain, reduced exercise tolerance, and the presence of an S3 heart sound, along with echocardiogram findings of left ventricular dilatation and reduced ejection fraction, all suggestive of heart failure. In the setting of a patient with risk factors such as hypertension and hyperlipidemia, CAD is the most likely underlying cause. CAD leads to ischemic heart disease, which can cause myocardial damage and result in heart failure with reduced ejection fraction. Myocarditis typically presents acutely with signs of infection and a rapid onset of heart failure symptoms, which is not the case here. The most common form is a viral infection and is preceded by a typical upper respiratory tract infection. Echocardiogram helps rule out other causes of heart failure. Definitive diagnosis may require CMR imaging or endomyocardial biopsy. Valvular heart disease can lead to heart failure, but would likely show specific valvular abnormalities on echocardiogram, such as stenosis or regurgitation, which were not mentioned in this case. Hypertension is a possible cause of heart failure. However, In the presence of coronary risk factors and the fact that the EF is less than 40%, CAD remains the primary concern. Consider hypertension as the cause if the patient presents with heart failure with preserved ejection fraction, defined by an LVEF of more than 50%. Heart failure with reduced ejection fraction, also called as HFrEF, is defined by an LV ejection fraction of less than 40%. This is due to impaired myocyte contractility and dilated heart, leading to reduced stroke volume and left ventricular ejection fraction. The common causes of HFrEF include CAD, obesity, hypertension, diabetes, and valvular heart disease. Heart failure with preserved ejection fraction, also called as HFpEF, is defined by an LV ejection fraction of more than 50%. This is due to an inadequate relaxation and filling of the ventricle but normal myocyte contractility. The most common cause is hypertension. Heart failure with mildly reduced ejection fraction is defined by an LV ejection fraction between 41% and 49%. Heart failure with improved ejection fraction is defined as a previous EF of less than 40%, but a follow-up measurement revealed an EF of more than 40%. A 65-year-old man presents to the clinic complaining of shortness of breath. He reports that he has been experiencing difficulty in breathing, particularly when bending over to tie his shoes or when gardening. His past medical history is significant for hypertension and myocardial infarction. He has been adhering to his medications, including a beta blocker and aspirin. On physical examination, his blood pressure is 140/90, heart rate 78, respiratory rate 16. Auscultation of the heart reveals an S3 gallop. Lung exam is clear. Lower extremity examination reveals a +1 pitting edema. Which of the following is the most likely explanation of his patient's symptoms of dyspnea on bending over? Is it orthopnea, PND, or bendopnea? The correct answer is bendopnea. This patient's symptoms of shortness of breath upon bending over is described as bendopnea, which is a sign of heart failure. Bendopnea is a term that refers to shortness of breath when bending forward and is thought to be due to an increase in intra-abdominal pressure, which in turn increases the pressure on the diaphragm and reduces lung capacity. The symptom is particularly indicative of fluid overload in heart failure, especially in the setting of known cardiovascular disease and supporting signs such as S3 gallop and peripheral edema. Symptoms of heart failure include those due to volume overload and those due to low cardiac output, that is most pronounced with exertion. Symptoms of volume overload include dyspnea, weight gain, orthopnea, and PND. Bendopnea is dyspnea when leaning forward and is due to an elevated filling pressures and associated in setting of reduced cardiac index, as discussed previously. Findings of low cardiac output include reduced cognition, low pulse pressure, cold extremities, and low blood pressure. A 58-year-old female presents to the emergency department with complaints of increasing shortness of breath over the past 2 weeks. What is the most likely cardiac finding in this patient? S1, S2, S3, S4, or pericardial friction rub? The correct answer is S3 heart sound. An S3 gallop, an additional heart sound detected during early diastole as the ventricle fills, is caused by the abrupt slowing of blood from the left atrium to the left ventricle. This finding may be normal variant in young, healthy individuals, but can also be indicative of congestive heart failure, dilated cardiomyopathy, or volume overload. It is best auscultated using the bell of the stethoscope placed over the apex of the heart. Symptoms are the same for HFrEF and HFpEF. Symptoms and signs that increase the likelihood of heart failure includes paroxysmal nocturnal dyspnea, which is PNB, and S3. The likelihood of heart failure is decreased by 50% if there is an absence of dyspnea on exertion or absence of crackles on pulmonary auscultation. The clinical diagnosis of heart failure requires simultaneous presence of at least two major criteria or one major criteria in conjunction with two minor criteria. This clinical diagnostic tool is highly sensitive for the diagnosis of heart failure but has a relatively low specificity. The Framingham diagnostic criteria are as follows. Major criteria includes acute pulmonary edema, cardiomegaly, hepatojugular reflex, neck vein distension, PND or orthopnea, pulmonary rales, or S3 gallop. The minor criteria include ankle edema, dyspnea on exertion, hepatomegaly, nocturnal cough, pleural effusion, or tachycardia. A 56-year-old male presents to the emergency room with complaints of increasing shortness of breath, orthopnea, and swelling of the legs that have progressively worsened over the past few weeks. He has a past medical history of hypertension and type 2 diabetes. On physical examination, you note bilateral rales halfway up both lung fields, an S3 heart sound, and 2 plus pitting edema in the lower extremities. His EKG shows no new changes. Which lab test would be the most helpful in confirming the diagnosis of acute heart failure in this patient? CBC, serum electrolytes, liver function test, or BNP? The correct answer is D, brain natriuretic peptide or BNP. Biomarkers such as BNP is the next best step once the patient meets the diagnostic criteria for heart failure based on the Framingham diagnostic criteria. Natriuretic peptides such as BNP or N-terminal pro-BNP is ordered as part of the initial blood test for patients with symptoms and signs of heart failure. Natriuretic peptide is helpful to differentiate if the cause of the shortness of breath is cardiac versus pulmonary. Most patients with heart failure who experience dyspnea have a BNP levels above 400. In contrast, BNP levels below 100 strongly indicate that the heart failure is not the cause of the dyspnea. For plasma BNP between 100 and 400, the sensitivity and the specificity for diagnosing or ruling out heart failure are relatively low. A 65-year-old female with chronic heart failure is being managed on sacubitril valsartan. During a routine follow-up visit, she reports feeling more fatigued than usual and has noticed a mild increase in her baseline leg swelling. Her physical exam shows mild jugular venous distension and trace pedal edema. You decide to check a marker to assess her heart failure status. Which biomarker would provide the most accurate assessment in her heart failure in the context of her current medication? BNP, N-terminal pro-BNP, troponin I, or CRP? The correct answer is N-terminal pro-BNP. In patients treated with sacubitril valsartan, which is a combination of angiotensin receptor blocker, valsartan, and neprilysin inhibitor, sacubitril, plasma BNP levels will increase because the neprilysin inhibitor prevents BNP breakdown. However, N-terminal pro-BNP remains a reliable marker for heart failure, as its levels are not influenced by neprilysin inhibition. N-terminal pro-BNP remains a reliable marker for assessing the severity of heart failure in patients treated with sacubitril valsartan. Elevated levels of N-terminal pro-BNP in this patient would accurately indicate a worsening of her heart failure condition, making N-terminal pro-BNP the most appropriate choice for monitoring her status. A 72-year-old male with a history of chronic heart failure presents to the ED with complaints of nausea and decreased urine output over the past 2 days. He denies any new or worsening chest pain, palpitations, or dyspnea. His medications include lisinopril, metoprolol, and furosemide. On examination, his blood pressure is 150/90, heart rate 88, respiratory rate 16. His lungs are clear to auscultation, and there is no peripheral edema. Lab tests show a creatinine of 2.9, increase from baseline of 1.1 a month ago, and a BNP of 900. What is the most likely explanation for the elevated BNP in this patient? Is it worsening chronic heart failure, acute MI, acute renal failure, or pulmonary embolism. The correct answer is C, acute renal failure. BNP is primarily used as a marker for the diagnosis and management of heart failure. However, BNP levels can also be elevated in other conditions such as renal failure. In patients with renal failure, decreased renal clearance can lead to an accumulation of BNP in the blood. In this clinical scenario, the patient presents with symptoms indicative of acute renal failure, such as nausea, decreased urine output, and significant increase in serum creatinine from his baseline. The absence of worsening heart failure symptoms like new or increased dyspnea, chest pain, or peripheral edema, and the presence of clear lungs on auscultation suggests that the elevated BNP is more likely due to his acute renal failure rather than a primary worsening of his heart condition. Thus, the increase in BNP should be interpreted with caution, considering his renal status, rather than directly attributing it to exacerbation of heart failure. Elevated BNP levels, even in the absence of heart failure, can be influenced by several physiological and pathological conditions. Factors contributing to an overestimation of BNP levels include renal insufficiency or kidney failure, where the reduced ability to excrete BNP leads to accumulation in the bloodstream. Furthermore, advancing age naturally increases BNP levels due to changes in the myocardial structure and function, as well as alterations in the regulation of natriuretic peptides. Additionally, women tend to have higher BNP levels than men, possibly due to variations in cardiac load and hormonal influences that affect BNP synthesis and clearance. On the other hand, obesity is known to underestimate BNP levels, a phenomenon that may be attributed to increased BNP clearance or decreased production relative to body size. Adipose tissue might play a role in the sequestration or degradation of BNP, resulting in lower circulating levels when compared to leaner individuals. This effect can mask the elevation of BNP levels caused by cardiac stress, thus potentially leading to an under recognition of cardiac dysfunction in obese patients. Understanding these factors is crucial for accurate clinical interpretation of BNP levels, especially in the context of diagnosing and managing conditions unrelated to heart failure. The primary diagnostic modality for heart failure is an echocardiogram. An echocardiogram can assess the LV ejection fraction as well as evaluate causes of heart failure, i.e., LV systolic dysfunction, looking at LV diastolic dysfunction, or findings related to valve dysfunction. Patients with HFrEF often have dilated ventricles, and patients with HFpEF have normal systolic contraction and normal sized ventricles or concentric hypertrophy. CMR imaging can assess for myocarditis as well as hemochromatosis, sarcoidosis, and amyloidosis. Routine CMR imaging should be used only when clinical suspicion warrants it. The ACC and the AHA together classify heart failure by stages, with the first two stages being asymptomatic and the second two being classified by severity of symptoms. Stage A are those with at risk for heart failure. These patients have no symptoms, structural heart disease, or evidence of elevated cardiac markers, but risk factors are present. Risk factors include hypertension, diabetes, metabolic syndrome, cardiotoxic medications, or having a genetic variant for cardiomyopathy. Stage B is pre heart failure. Patients have no signs or symptoms of heart failure but have structural heart disease, evidence of elevated filling pressures by either invasive or non invasive assessment, or persistently elevated cardiomarkers in the absence of other reasons for elevated markers like CKD or myocarditis. Stage C are patients with structural heart disease and current or past history of heart failure symptoms. Stage D are patients with refractory symptoms that interfere with daily life or recurrent hospitalization despite targeted, guideline directed medical therapy. New York Heart Association functional classification is based on symptoms, and the patients can be classified using the following. Class 1 includes symptom onset with more than ordinary level of activity. Class 2 involves symptom onset with an ordinary level of activity. Class 3 are symptom onset with minimal activity. And Class 4 are symptoms at rest. A 65-year-old female with heart failure with reduced ejection fraction have an ejection fraction of 35%, hypertension, and hyperlipidemia. Presents for a follow-up visit. Previously, she experienced dyspnea and leg edema, which improved significantly after initiating treatment. Currently, she reports only minor limitations in physical activity. Her medication regimen includes carvedilol, spironolactone, lisinopril, and atorvastatin. Her blood pressure is 135 over 76, heart rate 70, and her lung exam reveals clear sounds, and there is no leg edema noted. What is the type of the heart failure, and what is the most appropriate functional class? In this patient, the type of heart failure is heart failure with reduced ejection fraction, since the patient's ejection fraction is 35%, and the appropriate functional class is NYHA 2 and ACC AHA class C. Now let's do some rapid fire key points on heart failure. The classic signs and symptoms of heart failure includes peripheral edema, dyspnea, orthopnea, PND, crackles, elevated central venous pressure, and S3 heart sound. The most common cause of HFrEF is CAD. The most common cause of HFpEF is hypertension. S3 is suggestive of heart failure, especially with symptoms of dyspnea, orthopnea, or PND. BNP of more than 400 plus shortness of breath is suggestive of heart failure. BNP of less than 100 plus shortness of breath is less likely related to heart failure. Order a N-terminal pro-BNP level if a patient is taking sacubitril valsartan instead of BNP. Factors that is associated with elevated BNP without clinical findings of heart failure includes kidney failure, female gender, and elderly patients. Factor that is associated with a low BNP, but the patient has signs and symptoms of heart failure is obesity. Thank you. This is the end of my talk on clinical manifestation and diagnosis of heart failure.